And welcome everyone to today's webinar, Driving Total Value Through Wound Care Standardization at Tower Health. On behalf of Becker's Healthcare, thank you for joining us today. My name is Giles Bruce. I am a writer-reporter for Becker's, and this is actually my first webinar, so I've just joined the moderating team, so I appreciate you being here for my first experience. But before we begin, I'm going to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation and have time at the end of the hour for a question and answer session. You can submit any questions you do have throughout the webinar by typing them into the Q&A box you see on your screen. Just to let you know, today's session is being recorded and will be available after the event. You can use the same link you used to log in today's webinar to access that recording. And if at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. And so, yeah, we're really excited about some of the topics our presenters are going to share with you today. Those will include impacts of standardizing wound care products and protocols, achieving care consistency amid wound care complexity, one provider's standardization journey, and then practical guidance and potential outcomes. With that, I'm pleased to introduce today's presenters. We have Rachel Clark from Mölnlycke and Liz Faust from Tower Health. Thank you both for being here today. Rachel is the Southeast Area Sales Director of the Wound Care Division at Mölnlycke, while Liz is a certified wound ostomy continence nurse and nurse practitioner at Tower Health, as well as a vice president on the board of directors for the American Professional Wound Care Association. Okay, so yeah, again, Rachel and Liz, thank you so much for being here today. Before I turn the floor over, I did want to pose a question to the group. Feel free to post your answers in the chat. The question is, what does it take to deliver high quality yet cost-effective care? While we're waiting for responses to come in, I'll turn the floor over to Rachel.
Thank you. Hi, everybody. Yeah, so that question is, what does it take to deliver high quality yet cost-effective care? And if only it were measured by a passion for helping people, right? Because that's why we're in this industry. And during these times, you're faced with multiple pressures from the clinical, economic, and patient experience point of view. And these challenges tend to be felt more acutely in areas such as wound care, or rather, the inconsistency of it throughout the care continuum, which raises the urgency to standardize practice. A lack of wound care standardization can lead to complex clinical and financial challenges, and this is what drives the need for standardization. Clinically, when there is variability in practice, protocols, and solutions, this can lead to variabilities in outcomes. In other words, unpredictable outcomes, and can compromise care. A large body of evidence shows that when patterns of care diverge widely, clinical outcomes are not predictable. And as a result, patient health and recovery may be compromised. From an economic standpoint, a lack of standardization results in unpredictable costs, such as reimbursement risk due to diminished quality and safety outcomes, higher product costs, increased staff time, both in determining a care approach and also time spent learning about various products and updates. And last, product waste. For instance, there may be some guesswork involved when selecting products off of the shelf, which means the product used may not be the right one for the job and must be replaced with another. So to effectively solve for these challenges, we need to look at ways to support, enhance clinical practice. Another trend that's driving the need for standardization, it's a new trend, is the investment hospitals are making in the hospital-at-home care model. Clinical and financial benefits of shifting care to outpatient and home settings can't fully be realized without aligning solutions, practices, and contracting across that full care continuum. For example, the same stage of a wound should be treated according to the same standard, regardless of whether the care is taking place in a hospital, at a wound care clinic, or at home. It is ultimately our goal to ensure every patient will receive the same level of care. This presents healthcare with a prime opportunity to standardize across multiple product categories to both mitigate increased expenses and improve patient outcomes. In particular, hospital supply chain management has the greatest opportunity to do so. They can transform their supply chains into a vital, collaborative, and strategic function. Creating this advanced, highly mature supply chain involves setting it up in two ways. One, having a supply chain management governance structure that moves from focusing on just the supply chain management team to a collaborative approach involving all stakeholders, in particular, clinical stakeholders. Second is having a streamlined process of providing proper information to help the hospital make the right decision for their patients and for the hospital. This is a process that includes data collection, an evidence-based review on products, a cost versus value analysis, and communication. And this is a framework that Liz and Tower Health also incorporated, in which she will walk you through further in this presentation. This is really a framework and a foundation to establishing a standard of care while using evidence-based protocols and solutions to drive total value across the care continuum. And this is our definition of what wound care standardization means. So why do you want to standardize or consider standardization? Based off of a marketing medtech analysis, it stated that 63% of customers want to improve patient outcomes. 60% of customers want to standardize on products and care protocols. 35% of customers want to reduce contracted price, and 33% of customers want to improve patient satisfaction. There is also an increased focus to standardize in large-size hospitals and hospital systems, and this specific article mentioned more than 500 beds. With that being said, we know there are challenges that we face when we're looking to standardize. So what are those challenges, and how do we overcome them? The first one is the balance of price versus quality. You have a contract region director or strategic sourcing analyst tasked to save $1 million in 2023. But investing in high-quality wound care products can be an initial upfront investment. So how do we partner with supply chain on a cost savings plan if we are already putting them not only at that $1 million mark, but now at $1.1 million to ensure our patients have the best products in place to achieve ultimate patient outcomes? Second is consistency in care across different patient populations and care facilities. You have 5 hospitals, 2 wound care centers, and a home health location. And you are tasked to have one standard of care, the same products, protocols, etc. 3, you are tasked to look at up to 200 SKUs in the advanced wound care category. And you're expected to reduce and standardize to 15 or less. That is a lot of clinician preference lists. And last, standardization does not mean cheap if it's not done the right way. We have seen time and time that choosing the low-cost products and looking at line item reduction savings can be a means of reducing upfront costs, but can result in suboptimal outcomes, such as an increase in HAPPYs, an increase in product and staff utilization. And during that contract period, over time, this can lead to an increase in cost versus creating a cost savings plan like we originally proposed this initiative would. The traditional approach to standardize through a line item reduction standardization and going with that lowest or lower price dressing was designed to reduce expenditures, but this may have the opposite effect. We can overcome these challenges by shifting our way of thinking in 2 areas. One, how we mitigate costs. We can move from that traditional approach of line item reduction with the lowest or lower price per dressing to a total investment care cost captured over the entirety of the proposed contract term. Second is we can set up an RFP process where we have routinely looked at up to 200 plus SKUs, put them into subcategories, and standardize starting with the highest utilized categories. And we can move to an outcomes-based standardization focused on quality measures, such as hospital-acquired pressure injury reduction efforts. Here's another question that I want to pose to the group, and feel free to put it in the chat box. What are the top 2 wound care dressing utilization categories in your facility or across your healthcare system? An example of an outcomes-based standardization comes out of a facility in New York City that I partnered with, who standardized across the advanced wound care portfolio with a happy reduction effort that led to results gathered over a 7-month period, including 63% reduction in hospital-acquired pressure injuries, $438,000 savings through treatment costs avoided, and an ROI of 132%, just over a third of the year. The transition to Mölnlycke for happy reduction needs was not only cost neutral, but it was a cost savings when combined with an overall transition to the advanced wound care category. Only 6 wound care dressings were converted to meet the 70% compliance threshold to leverage contractual opportunities, and they were able to standardize some of their highest utilized categories across wound care, including bordered foams, non-bordered foams, and wound fillers. So both clinical and supply chain goals were met. Rather than looking at the traditional way of standardizing, starting with subcategories, we can really shift to a model focused on what products we need to achieve outcomes, which will get you the same results of standardization. This is just one facility that was able to take a transformative model of a nursing-led improvement and apply this to a cost savings initiative within supply chain. Today, Liz will also walk you through her example within Tower Health, as they were able to achieve a wound care standardization throughout the continuum of care. So what would this outcomes-based standardization for wound care look like if it was replicated at your healthcare system? Because why reinvent the wheel when we can replicate and implement evidence-based practice with known clinical and financial results? And what makes Mölnlycke different than any other advanced wound care vendor on the market? The first step that we want to partner with you on is doing a supply chain needs assessment. This is an opportunity to discuss strategies, goals, and data management. For example, a healthcare goal is to lower costs without sacrificing the quality of care. For supply chain, the goal is to lower costs, let's say by $500,000 across the wound care category, but to be able to leverage all benefits of the contract. And a secondary goal is to reduce the number of SKUs. From the clinical perspective, the team is aiming to standardize the practice of care across the system. And the cost of HAPPYs is creating an urgent need for a practice change to optimize happy reduction efforts. Now, what Mölnlycke can do at this point is we can conduct a traditional cross-reference addressing utilization analysis, where we can compare the current products you have to Mölnlycke's product portfolio. This really gives us a basic understanding of where you are and where you want to go. Now it's time where we can formalize and assist in developing a process improvement plan. This is going to align on the strategy to reduce SKUs, simplify protocols, outline quality measures. And one of the most important concepts that we have to start doing is calculating what the ROI percentage is and financial savings so that we can report back to supply chain management. It is important that I mention we know every facility is different. Not every hospital or healthcare system is the same. However, Mölnlycke's intuitive program for wound care standardization is customizable. We have the same framework and formula based off of a lean methodology that is proven to show both improved outcomes and significant financial savings. So this program, not to go into too much detail, really focuses on 3 major milestones. It's a standardization development plan, an implementation plan, and a continuous partnership. And this is where we deploy our team of resources, consisting of contract, clinical, sales leaders, including a WOCN and a health economic manager to be a part of this entire process. Each milestone is comprised of key components. In the standardization development plan, this consists of a review of evidence. The NPAP guidelines recommends the use of a 5-layer soft silicone dressing, and Mölnlycke has more than 114 pieces of evidence, including 7 RCTs, supporting our bordered foams and their efficacy for pressure injury prevention. We then want to assess the current HAPI rate to determine the rates and the financial impact. We then determine products, protocols that will be implemented to establish consistent system-wide processes and practices. And then we apply published evidence or your own hospital's evidence to predict what this change could yield, such as 88 to 100% reduction in HAPIs, and it could save over $1 million to your healthcare system when it comes to outcomes. Then we move into the implementation plan, which really covers the first 3 months of the conversion. It includes pre-education, product audits, and ongoing support, including in-servicing and CE programs. Last but not least, most important is our partnership. We are a company where we aren't just going to walk away once we have product on the shelf. This is where our real work comes in. Over that 12 months, we are going to help you and work with you to measure outcomes specific to HAPIs. And quarterly, we will report back to you what that looks like and what that ROI percentage and financial savings can be. We also measure compliance. This is something where our team will come to the floor, each unit, and we will measure exactly the appropriate use of the product, making sure you're capturing the high-risk patient population and also capturing the appropriate application. And last but not least is we really measure the utilization. So Mölnlycke's approach to standardization requires the right mix of quality products and value-added services. And this is just one snapshot here on your screen of what going from 200 plus SKUs to a simple 6 concept or a 9 for 90 concept can look like. It means that 9 of your products can support 90% of your wound prevention and management needs. With that being said, I appreciate everyone taking the time to hear from my perspective and Mölnlycke's perspective on the importance of standardization. But I don't think there is a better way for all of you to truly understand the significance of what I'm starting to say and talking about without hearing from one of our customers that went through this process with her healthcare system as she's worked as a clinical stakeholder to provide optimal patient outcomes and to mitigate increased expenses while doing so. So Liz, I want to turn it over to you.
Thank you, Rachel, and just thank you, Beckers and Mölnlycke, for helping put this together. It's really great to talk about what I would call my baby, but a baby would have been delivered after 9 to 10 months, and this was a much longer endeavor than that. And certainly I think COVID had something to play into that. I think when in doubt, blame COVID, right? So, just from my perspective, just to introduce myself a little bit further, I'm a nurse practitioner. I work at a level 1 trauma center in Eastern Pennsylvania. 4 years ago, 3.5 years ago, I was just one of the wound care clinicians. I was one of 3 working at our large wound care inpatient trauma center. And as the pandemic hit, we started to be mobilized to other hospitals within our system. And ultimately, I switched from being employed by one hospital to being employed by the health system, which dictated that I went from full-time clinician to having some administrative responsibilities as well, which is why I am the one on this call for Tower Health. So just an overview of Tower Health. We're a fairly large health system. We serve 2.5 million patients. We have 5 acute care hospitals, 2 wound care centers, and a home health agency titled Tower Health at Home. Organizations everywhere face critical challenges, and when you make a decision, you really, it impacts the system in either small or large ways. And things such as standardization, even a small change has a large impact. And so I think that's really important to consider because it's just multiplied so much more when you have a larger health system. Okay, so what we really wanted was a consistent framework for diversity of care needs. And so just to give a little bit of background, the needs of the hospital, the provider, the unit, and the patient can be so different. So healthcare organizations and clinicians are kind of tasked with finding solutions, much like Rachel said, where 9 things can meet 90% of the needs of the patient, and all of that kind of within a similar capacity. So the other challenge is that the culture and the restrictions or regulating bodies for each of these places is different. So the focus at my home health agency is much different. They want to decrease visits and decrease costs of the dressing. In the acute care setting, they want to limit how many times they have to change the dressing because nursing time is really expensive. And then within the operating room, they kind of want to set it and forget it, right? They want to prevent pressure injuries within any really area, but then they also want to ensure that their incision is covered with something that's evidence-based and can kind of be their insurance for that patient. So in trying to manage everybody's needs, it can be very challenging. Obviously, I think that's why we're all here, right? So Tower Health really looked at standardizing the knowledge. So when we looked at all of the facilities, we had really good clinical resources at some, but not all of the facilities. So that really limited what we could do from each facility. We had to babysit that process a little bit more. So we had to make sure that it was something that the education didn't require a clinical specialist. The education could be communicated at any level. Because, staff as resources were now pawn pieces. They were being used across the system, and, we were kind of shifting them. So things that we used to take for granted as far as having a resource may not have been there anymore. And even just being able to access some of the resources, particularly during some supply chain crisis, was not there as well. Ensuring all types of patients and wounds were covered. So, there's no specialty and really no clinician within the system that's immune from needing to know the wound care practices of the system. I honestly come in contact with so many diverse people and specialties. I think I've received consults from every specialty within the hospital and outpatient setting as well. So you really have to cover that continuum. So one of our hospitals is a pediatric hospital that's both a trauma and burn center. And so you would imagine that the needs of that institution would be so much different than perhaps our smaller community hospital or our home health agency, our wound care centers, or our level 1 trauma center that's much larger, or even our rehab hospital. So there's so much variety even within it that to find something that could, again, 9 on 90, really meet the needs of the system was really important to us. Also within these institutions, we had 3 NICUs. We had, the level 1 trauma center as well. So we really wanted to be able to cover from birth to death and even premature birth to death is, I guess, what I want to say too. Something that was safe and effective where we didn't have to have all these smaller nuances within it. The other challenge is, we're teaching institutions. We get new residents all the time. They rotate in different facilities. They have different verbiage based upon their training. Surgeons often tell me they do what they're told in their training. And so if everybody's coming from a different culture, they're going to bring different expectations and different brands and different things with them. So if we can easily say, all right, this is the category you're looking for, this is what we utilize, it makes it a seamless process. We also wanted to ensure not just all types of wounds, but that we were prevention to treatment. So we had options for, if we needed to prevent a wound or if we needed to treat it. And sometimes it's the same dressing, which is great, right? As far as removing the variables, particularly around specialties, standardization really helps us speak the same language. So as a system, we decided collectively to say, okay, when a patient is admitted to one of our hospitals, the care and the expectation of care that they would get at hospital A will be the same as hospital B for the same diagnosis or the same risk or the same surgery. And really that arms every clinician with a toolbox to be able to care for the patients no matter what it is. So if it's a skin tear or if it's a very complex necrotizing wound, we have something kind of across the continuum. And then your comfort level is so much better with that dressing because you're utilizing it in a variety of different ways. And to me, that was so important because once the language is the same and the comfort level is the same, it makes my job of getting consulted for a variety of different wounds much easier. Half the time now, people are already putting on a dressing that I would have recommended because there's clear guidelines and clear language. The other really great thing that I just like to mention as we are standardizing is it's really nice to have it from one company because based upon packaging, people can recognize the differences between two different dressings if it's from the same company. They may not be able to do that if it's from a different company. And I just think that that's an important piece because I feel like so much was wasted when we didn't have the standardization because people would grab the wrong thing and then bring it into the room and then we owned it, right? Once it's in the room, we own it. So partners in progress. So really I have to thank Mölnlycke. They have been great partners. They have worked with me throughout the entire process as I sat with supply chain, as I sat with storeroom, as I sat with my clinicians. So really we identified our key stakeholders, obviously, as we need to. The project team really included both clinical and supply chain personnel. So our wound ostomy continence nurses, that's what WOCN is, just in case you don't know. Our supply chain leadership, the storeroom leadership, and then nursing professional development practitioners, so like our nurse educators, our clinical nurse specialists, and then, of course, like our specialists and generalists. So, the majority of the providers here are hospitalists, but surgical staff as well. We also had some education of our nursing staff, particularly in the outpatient arena, since they're the one really guiding the selection, and then our outpatient wound care centers as well. We're kind of critical in this process. And I'll explain in a little bit more depth the process of our decision-making in this next slide. So, this slide puts it in 5 steps, and it seems very easy, but there's a lot of sub-steps underneath this. I just watched a LinkedIn Learning by Mike, I'm not going to say it right, Figulio. I don't think I said that right. But it's called The Timing of Decision-Making. And he really says that there's 5 steps. It's prepare, decide, communicate, execute, and then measure and adjust. And so really the 5 steps we laid out here is just similar to any other decision-making process in that sense. So in the prepare or kind of planning phase here, we really identified gaps and redundancies in the system. And I'll say we just kind of reviewed what was out there. So we pulled all the SKUs of advanced wound dressings, preventative treatment, anything across the system to see what was being utilized. It's quite eye-opening to see how many different SKUs we had out there. Similar products. We had like retired products that were still active within our purchasing system and things like that. So once we identified all of these products, we also identified who the key stakeholders were going to be, and we kind of defined how we were going to judge this, what our criterion for judgment was going to be. So we defined our options, we identified our stakeholders, and we identified our baseline data. So then in our deciding phase, that's when we did this kind of touch, feel, play trial. So the initial send out, I wish I would have had it with me. I had like a little ring, and on that ring there was all of the dressings that we were going to look at. And so we had some for company A, we had some for company B, we had some for company 3 or C. And then we kind of sent it out to the masses, and the evaluation tool for them was the same. And so we did something called a 5th to 5 rating. 5th to 5 rating means like the 5th is that I would actively fight this if you try to bring it in. And then 1 is like, I don't really like it. 2 is like, nah, it's not my flavor. 3 is neutral. 4 is like, yeah, it's okay. I support this. And then 5 is like, I love it. Let's do it, right? So all of the clinicians got that with commentary. And so for every dressing under every category, this is what we did. This was the time, my error of spreadsheet. So every spreadsheet was a different company with different categories, and we kind of just looked at it. So the nice thing about the 5th to 5 data is it gives you tangible and results that you can objectively analyze to say, okay, the rating for this specific dressing was this number. And we had 0 negatives because, there was no 5th, or we had 5 5th, and then the overall rating was this number. So I really like that because I think I'm more of a black and white thinker when it comes to the analysis, and that really made it a tangible thing. And then because we accumulated that data, we were able to share that with all the stakeholders. So those who looked at the dressings, like our clinicians, our storeroom, our supply chain, our leadership, our fiscal partners, and also Mölnlycke. We were able to give the other companies feedback about what the clinicians liked and didn't like, should that ever be helpful to them. So that was really our establishing criteria. Now, some of the people on that 5th to 5 say, I like the design, but I want to try it on patients. So step 2 of kind of that evaluation was, okay, now we've narrowed it down. Let's really hone in and see what can we do in order to help us learn more about how it works in vivo. Okay, so in vitro it looks good. In vivo, maybe it's not going to work as well. So we allow clinicians time to trial those products, utilize it on real-world patients, provide feedback to us, and then ultimately we propose a formula. And so kind of this is the 3rd edit then. That formula we sent out to those key stakeholders again, looking for, kind of that last buy-in, and then finally we signed the contract, right? And so then we started working with the team to start clinical education, create posters. We've updated our policies to be brand specific to say, nobody knows what a 5-layered sacral silicone bordered dressing. Nobody knows that. I do, and Mölnlycke does. But if you ask a clinician what a 5-layered foam bordered dressing is, they're going to be like, I have no clue. So to have just that very specific language of a MAPWCA border flex or a MAPWCA 1, like that's what they need. Especially when the language is so close together, like you need to be very specific. So we were able to integrate that as well as within our EHR, which was also very helpful. We have our pressure injury prevention and treatment guidelines, as well as our skin tear and moisture-associated skin damage guidelines built within our EHR as wound care orders. So any provider or nurse who is following our protocol orders can select the wound type, and then a drop-down of all of the guideline orders will be there. So You can select any of the guideline orders, and then you've already implemented kind of the treatment plan for a patient that's within the company policy, evidence-based practice, and within our standardization. So it's really nice to have that built in, and I highly recommend it. Okay, so we've got our prepare, decide, communicate, we executed it. One of the biggest opportunities with the execution was real estate. So we mentioned that we had a lot of time to speak with our storeroom, and part of their concern was that if we were bringing in new products, that we wouldn't have space for it. But what ultimately ended up happening was, because we were streamlining to products and streamlining our sizes, we were able to find like volume and sizing needs for each of the areas. Now that was very tailored. So the NICU, even though they're using the same formulary for the rest of the hospital, their formulary might be more specific, right? So they have MAPWCA, but they have MAPWCA in the 2x3 size and not in the 6x20 size, okay? So it's very unique to the patient population. Burn has its own formulary. NICU has a formulary. Adult has a formulary. Home health has a formulary. But it's all within the same standardization project. So that's where your clinician feedback is really important, and where they feel like even though there was a larger decision made for the system, they're still getting their needs met. And I think that's really important, and the stakeholders identified that that was important, and they were happier, which means that they were more trusting and more willing to engage and participate, which was great. And then finally, it's the measure and adjust. So, you know, if a project goes off without a hitch and works perfectly your first go-around, please have me join your team, because that never happens. So obviously just being open to being able to adjust as needed, maybe an assumption that you set out when you were initiating a project really didn't come to fruition once it was in vivo. You know, have the ability to adjust and kind of redo this process of prepare, decide, communicate, execute, measure, and adjust. So it was a big learning process, and I'm really happy that we went through it, because I think our benefits and takeaways are really important for you here. So, excuse me. So our results to date. So we went from 134 wound care SKUs to 72, which is a nice reduction, you know, almost half. And then we went from 14 vendors to 9. So that was also big. We had focused training, which had fewer variables, more evidence-based, and streamlined supply rooms, easier on clinicians. So I think that was really, really important, that kind of real estate aspect. So I think that was one piece that in some of my initial standardization projects with the system, I didn't value the input of supply room as much, so our clean utility rooms. If you set something in place but you don't involve that key stakeholder that's going to put it on the shelf and make sure it gets restocked, your entire implementation will fall apart. So I really, really urge you to make sure that they are key partners in this, and that you don't dictate things to them, that you actually ask them. That definitely helps a lot. You know, I once heard of a hospital that used one brand for prevention and one brand for treatment, and I thought that was like really fascinating, because they would have the exact same product category and size of dressing right next to each other, but they deemed one was for prevention and one was for treatment. And that, when I asked why, they said, well, the one dressing's more expensive, so we only use it for treatment. And this one's less expensive, so we only use it for prevention. And I just thought, well, maybe if you use the more expensive one for prevention, then you wouldn't need to use it for treatment. Was what I was thinking in my head, but I digress. But that was certainly also confusing for staff, particularly in the age of traveling staff as well, because not only do we have traveling nurses and respiratory therapists, but we also have 10A locums and residents that are coming in and out as well. So some of the key learnings was that if clinicians had experience, we didn't need to pause our process in order to develop a trial and really babysit that process. And that was really helpful for us. I think, as I mentioned, education, including our policies, can be very product specific. And then non-clinical stakeholders can see an impact of product utilization and clinical appropriateness. So, making sure that there is a key stakeholder that is like the advocate for supply chain is really important. I was pretty lucky in my opportunity to be able to serve my wound care clinician colleagues in being kind of the voice with our supply chain, because a lot of times there is such a broken ladder in between the bedside clinician or the end user and those who are empowered to make the decisions. So the things that my non-clinical stakeholders like supply chain and the C-suite people really cared about was like how much usage can we streamline and what is the clinical appropriateness. So that's really what we wanted to focus on with them. Whereas my clinical colleagues wanted to be like, what's the wear time? Is it going to stick? Is it painful? Will it help with bacteria? Kind of all of these other questions. So being able to address both sides of that was really important as well for this process to go smoothly. And I think the other thing is that, time can be a huge barrier to this. I mean, like, as I mentioned before, I would call this my baby if it had taken 10 months, but this is more of like almost a 2-year process from start to finish. And I think as supply chain has had so many other priorities with subs and just supply chain in general is so chaotic, and then staffing changes. For me, if I would get pulled into a clinical situation or if it was a COVID surge, I would get pulled to be proning patients in the ICU all hours, and my priorities were not to work on this project. What's great is that we had teams and that we could just meet, kind of on demand. But from going through these processes prior to COVID, I do know that meeting in person and having those working meetings was much more beneficial in making the process go smoother. So the process is really worth the rewards, though, because in the end, the standardization project is going to save time and money. Nursing time is really valuable, and it's so important to measure that. And then as far as money, I know we had shown just within our trauma center by standardizing our skincare protocol to a 7-day dressing versus a daily dressing, we were able to save significant amounts. So once we were able to standardize that across the 5 hospitals, we multiplied that savings even more. And so that's just one example of how standardization is great for both time and money. And really, we have like elite products. Is at least that's the impression of our clinicians. Sometimes I tell people, oh, well, this is the Ford model. There's Cadillacs out there, but the Ford meets pretty much everybody's needs. And I'm sorry if anybody's a car snob in any way, shape, or form, but it's just my analogy, not being a car snob. And I really think that we get to have the Cadillac because I feel like Mölnlycke products are like kind of the nicest product out there in terms of advanced wound dressing. And we're still saving money, and the clinicians are happy, and we're able to standardize. So for me, it's like a win-win-win. And even like our supply chain is happy about it because we have been able to show a fiscal impact and decrease our SKUs and make it much more streamlined for ordering. So a strong partner really cuts through the clutter. You do need to lean on an experienced partner to help you roll out this program, and really Mölnlycke has helped me in so many ways with this. They really focused our wound care portfolio, like I said, to meet that 90% need. We provided clinical evidence and financial data, and quickly. I mean, very much a partner. Hands-on training to establish consistent processes. They have no problem bringing in their clinical education team on all varieties of things. So, whether it be the boots or repositioning devices, whether it's the advanced wound dressings, whether it's surgical dressings, burn care, they were welcoming to all of that. So, and then they really not only matched the product, but they matched the clinical data. So it's really important to me in wound care where there's not as much real-world data and evidence-based or higher-level data to say, like, we do support that with this. And I have to thank, my rep Kylie has been really great. My educator Katie have been really great in providing that to all of our hospitals and institutions. And not just for nursing, but for the surgeons, for the respiratory therapists, because of course some of these dressings are really important in preventing pressure injuries with medical devices, which is kind of a hidden source of higher fees in the hospital here. So, and I think with that, I'm going to hand this back over to Rachel just to talk about how the story doesn't really end with just the standardization part. Rachel?
Thank you, Liz. It was wonderful just being able to hear, what impact you were able to make both clinically and financially. And as Liz says, it really is a team approach. It's a partnership that we can work with your facilities on. And just kind of segueing into what Liz mentioned of this story doesn't end with just standardization for wound care. Wound care really is just one aspect of being able to optimize care to deliver total value. And when I kind of mentioned in the beginning of the presentation that there's clinical challenges, there's economic challenges, and also that patient experience point of view, in areas such as infection prevention, pressure injury management, clinician safety, we really feel these challenges as well. So we think of this from different perspectives. So really, depending on what focus that you have right now in your healthcare system, we really want to have that opportunity to be able to show you the different solution bundles that we can provide to address all of these areas, including that wound care standardization. And as we've discussed today, the standardization and vendor partnership process is more than just product selection. And we really want to move from that transactional viewpoint to really that overall partner. And this is all about being able to achieve your enterprise-wide goals by together formalizing and assisting in developing an intuitive program and a plan that really aligns with your strategy, and also being able to meet your goals both clinically and financially. So we appreciate everybody that spent this hour with Liz and I today. And as you can see, this is really just that partnership story that we wanted to provide to you, and really hearing from Liz and Tower Health and the success that they've been able to achieve, because it is not an easy task, as Liz said, to be able to standardize across the care continuum. But I also want to make you aware that at the bottom of the screen, there are options to learn more about Mölnlycke and to also speak to myself, Mölnlycke, as well as Liz directly. So we would love to work with you really in your wound care standardization if that is a challenge for you, or just to discuss with you the process of being able to really bridge that gap from clinical and supply chain and finding the balance of price versus quality. So now we will go into our questions and answers.
Okay, well, thank you, Rachel and Liz, for the great presentation today. Yeah, I really learned a lot, myself even, as someone who's a health IT reporter and usually in that world. So it was a really interesting conversation today. So we're going to now begin the question and answer session. You can still submit any questions you have by typing them into the Q&A chat box on the webinar console. Let's get started with the first question. This one is for Rachel. So how agreeable was materials and value analysis to standardize Mölnlycke products? Did you meet any roadblocks with them? And if yes, how were they overcome?
Great question. I think that supply chain and also the clinical side, they want to standardize. I think that you're able to really achieve outcomes that way, but there absolutely were roadblocks. I think the biggest thing is financially. So we really just need to make sure that that financial component is going to be attached to the clinical outcomes, because over, the course of a contract period, let's say it's 3 years, that's where you can really start to save on your outcomes-based standardization versus just looking at that lower price per dressing. So if you're able to really make sure you have a partnership in place where the vendor is going to be able to help you track data and be able to plug in that financial story, that's the way to really overcome that, because then you're achieving both sides, financial significant savings as well as clinical.
Okay, great. So this question could go for either of the two of you. So what documentation charting templates are optimum for reimbursement?
So I'm going to say that this is probably for the outpatient setting, more so, because reimbursement is definitely more important there. As far as in terms of reimbursement, it's really identifying the need for a product. So anything that would document the size, the depth, the drainage amount, and the kind of peri-wound condition, things that Medicare is looking to have in order to have coverage for certain dressing supplies as an outpatient are really those factors: the size of the wound, the depth of the wound, and the category of the wound. So most EMRs that have some wound care documentation, that's important. The logistical piece to that is that certain EHRs and certain third-party apps for EHRs can do that better. It's probably an entirely different webinar that we could probably go into that about use of technology with wound care. And, if somebody wants to sidebar with me or peek anything with me, I'm more than happy to discuss that kind of outside of this webinar.
Okay, and quick follow-up to that, because we had a question related to that. So which EHR are you using?
So I use Epic within our system, yeah.
Okay. Next question is for Rachel. So how often are you hearing the desire to standardize from supply chain versus clinical voicing? Sorry, this one cut off.
Yeah.
You go ahead.
No, from the supply chain standpoint, I think, it really is their due diligence to always look at standardization and always to review contracts and to kind of provide opportunities for vendors to look at cross-references to see where they can continue to reduce SKUs, where they can continue to save. But I think now more than ever, clinical stakeholders are really starting to be involved, because in order to have that fiscal and cost savings long-term is going to come with improvement in patient outcomes. So I really do think that now the desire to standardize is really coming from both sides, but I think it's starting that shift where now clinical stakeholders are involved in that process. Liz, is there anything you want to add to that question?
Yeah, for sure. From a clinician standpoint, I get plenty of cold calls. I get lots of people reaching out to me in a variety of different ways, whether it's calling my office, emailing me, LinkedIn messaging, or showing up on hospital campuses to say, my products are awesome, I'll save you a ton of money, and we're on contract, or, you're going to love us. And ultimately, it's nice when you have something that your supply chain says, look, we've investigated this, we know this is an initiative, other health systems are doing this, would this be something we'd be open to? Or when they actually are open to you being the driver of it. So when I first started in wound care, 13 years ago, it was really clinician-led supply chain. And probably 10 years ago, we just felt like we didn't have a voice anymore. And now I think we're getting back to a point where supply chain and clinicians can partner. But it's really important to clearly define the criteria, just define the decision-making process. So many clinicians are we don't even know where to start. Who do we even talk to? Is this just for my site, or is this for the entire system? So there's so many different pieces to it. So if you are on the administrative side, knowing your clinicians might have real-world data for their specialty that could save you money, but they may not know the pathway of trying to communicate that. So ensuring that you can have a defined process for product selection is so, so important.
Great. We just had a question come in for Liz. So what were the most important clinical outcomes that drove your decision-making process?
Yeah, so honestly, absorption of our products, the evidence that showed that there was good prevention, as well as the SafeTac technology. So SafeTac just shows that it's safe and efficient for the epidermal stripping, so it's good from neonates all the way up. There were some nuances that particularly our NICU didn't like, and with having our trauma center, there's just specific needs for specialty populations. So as evidenced by the 2019 NPIAP, EPUAP, and TPIAP guidelines for pressure ulcer prevention and treatment, there's very clear guidelines for specialty populations, including pediatrics, critical care, operating rooms, spinal cord injury patients, and we care for all of those patients across all of the care continuum. So really, we needed something to meet all of their needs, and the other industry that we looked at just didn't have that. And so we needed to ensure that that happened. Plus, we had experience in most of our facilities with some of the dressings. So there was a level of comfort with it as well. And they trusted that brand dressing to deliver because they've used it before.
Okay. And another question that came in, one that is the type of question I would ask as a journalist, because I always like to get into the human side of healthcare. So wound care is such a passionate space. So how is the emotional aspect of this managed? I assume that would be for Liz, but Rachel, feel free to jump in as well.
The emotional aspect, well, I think that was managed over coffee and cocktails. No, I'm kidding. I'm joking. No, I think as with any decision-making process where there's challenging decisions and clinicians feel so passionately, it's important, number one, to understand their perspective, where they're coming from, and what's driving that emotional intelligence is what I'll say. And then if a decision is made and, they may not agree with it, I think the most important thing is carrying through with being authentic about the rationale behind it. So giving them as much information as we can if it's a decision that they don't like, and saying, we're always measuring and adjusting and blah, blah, blah. But, you can't please everybody, but you can talk to them about the decision-making process and just be authentic in what is happening behind the scenes as much as you can be transparent with them.
Great. Thank you for that. And then one final question, because we're running out of time here. So how did value-based care and digital transformation play into this process? So
I think that's actually really important in the outpatient areas, much more so than the inpatient areas. Our home health agency was very excited to standardize to Mölnlycke because they were aware of the extended wear times that they could get in between dressing changes, the enhanced absorption capacity that the gelling fiber has, and things like that, as well as the ability of the dressing to stay in place without causing further peri-wound skin damage due to the SafeTac technology. So for us, it really showed in the outpatient arena to have the highest values because of, in those settings, we're able to see more patients and decrease our visits per patient rather than seeing the same patient 2-3 times a week.
Great. Thank you, Liz. And unfortunately, that's all the time we have for today. I want to thank Rachel and Liz for an excellent, informative presentation, and for Mölnlycke for sponsoring today's webinar. I also want to thank everyone for being here for my very first webinar for Becker's as I get my moderating career started here, so hopefully I did okay. And to learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.